last but not the least, I've got a small 3-minute video. I have decided that with the number of complications gone up in my clinical practice, not to be very blowing my own trumpet, I have decided to share one set of, no, not this. It's just the video. Just keep the video on full screen. Yeah. So this is the case I have chosen for this year. Yadil, can you just start the video? Just let me control, you keep the video on. Yeah. Yeah, so I'll control the video, okay? So this year is dedicated to this case. So as many people can see how many ways I can screw up a simple case of around 90 degree, 120 degree subluxation. So those who have seen, please refrain from using the same abuses you used last time. And those who have not seen, you're free to say whatever. So this is basically a young male patient, traumatic cataract, fairly recent case. The patient was, for the first time, the father had brought his son to me because most of the time the sons get their parents to me for surgery. So this time the father had gotten operated by me and he was so happy he got his son. So this is the case. So I had not operated on a young child for a long time, so I had completely forgotten the capsules are elastic. So the first initial morning shows the day the rexes started running away. You have to remember there's no support here also because the zonules are dehiscent here. So elastic capsule with a dehiscent zonule, the rexes started running away. Anyway, the prolific surgeon I did manage to finish doing the rexes. The cataract removal was not that difficult. It was a soft cataract. So you see I have a nice round rexes in a nice round pupil, no vitreous. So next step, implant CTR. That is the logical thing. Go in through the main port, implant the CTR. The CTR started slipping out. So I didn't understand why it was slipping out. Everything was going so well. Why suddenly this is happening to me? So I tried to go in from the other port, one of the side ports. But this angle of attack was so acute, it was pushing the whole back to the other side. So I decided this is not the right way to proceed. So now I'm thinking what to do. So my method of thinking is use viscoelastic. Use as much viscoelastic anywhere in the eye as possible. Inflate the bag more, put it over the cornea, in the sclera, fornices, everywhere. So the definition of a fool is you try to do the same thing over and over again, expecting different results. So again, I go in through the main port and I try putting in the CTR, it wouldn't go in. Why it was not going in, I realized was this rexis is centered to the pupil and not to the lens. The rexis is so close to the edge of the equator that the overhanging edge of the anterior capsule offered no support to the CTR when it was going out. So I tried going in through the last hole in the eye, which I had, which is the second side port. This looked quite promising. It went in almost all the way, but whenever it was coming here, it was slipping out. Simple reason, I did not use hooks to stabilize the bag, and the overhanging edge of the capsule is so close to the equator of the lens, of the nucleus, that it was not offering any support. So then I decided to abandon implanting CTR at all. The gods must be looking down on me because still no vitreous, young male patient, so solid vitreous, thankfully. You can see the trauma in the posterior capsule, which also helped the capsule being fibrous. Otherwise, I would have damaged the posterior capsule also by now. So I tried to implant the multi-piece lens inside the bag because I thought maybe multi-piece lens would behave better than a CTR. I didn't know why. Again, it didn't work. So I decided to take out the leading haptic, which was already inside the bag, do an optic capture. Both the haptics are in the sulcus. And finally, I could get a stable lens. Since the pupil was centered to the pupil, rexis was centered to the pupil, the lens also stayed centered. And since this is not a progressive disease, thankfully or rather, as you know, I have been taught in my presentations, whenever there's a complication, always say we. And whenever there's a good thing outcome, you always say I. So we are thankful that we could achieve a decent outcome in this case. But ideally, in all these cases, first of all, you should always use hooks to stabilize the capsule. I have learned my lesson. And secondly, you should always implant the CTR early on. If I had, when I had started off my Rexis, first of all, elastic capsule, I should have started off much closer to my incision because the lens was pulled down. I did not realize that. I should have started my Rexis somewhere around here instead of here. And secondly, I should have used hooks at the beginning of the Rexis rather than trying to put a CTR at the end where it was not simply not possible to put a CTR. So that's the end of my presentation, and that's the end of this instruction course. So as we would have it dare to bear, we have finished before time also, starting after time. And I would like to thank the audience for enjoying their lunch here.
So why don't you show another disaster?
I don't, my hard disk crashed, so this was the last I had on my pen drive, so I carried it on from the last presentation actually. Any questions or anything else anybody would like to say? Yeah, yes, please. Oh, because, yeah, no. Because it's a soft cataract, so I did a hydro and the whole thing came out of the bag and I just aspirated out. The advantage, see, you always remember fortune favors the brave, especially brave men like me. Since this is a young male patient, the vitreous face, anterior vitreous hyaloid face is quite stiff and the vitreous is still gel. So if this was an adult male patient, this would have been liquid vitreous. Vitreous would have been in the anterior chamber from the very beginning and the case would have been different from the very start. So I was lucky with that. Yes, sir. A mic, can we get a mic, please?
So in this case, probably, I mean, if you had gone from the left side before removing the cataract, because see, the CTR was going in an empty bag. An empty bag that would go, even if you put high molecular viscoelastic, the moment you start putting it, it was slipping. So probably in case of, in subluxury, that's what I also never end up, or most of the time I don't end up in this sort of cases, a central, you can end up in a eccentric rexis. Then you can go from the other side and with the, I mean, just do a visco dissection, take out a channel and then put the, I mean, that time you get some resistance, so the normally doesn't move.
Yeah, it should have been that way. Actually, we have got another instruction course tomorrow, early morning, Dr. Paul's course only, where we are talking about ectopia lenses and subluxated lenses. There I've got some more bouquets of agonies and ecstasies. That is supposed to be my topic for tomorrow. So you can see some more agonies of mine tomorrow, similar cases. So it's not just that it's restricted to the fact where cases you don't have, you put the CTR later on. I have had multiple cases, as you will see tomorrow, early morning, where I have implanted the CTR very early on and still ended up with disaster. I have ended up with disaster without implanting any CTR in any stage of the case. So irrespective of CTR and the stage of surgery, I do manage to create complications. But I would like to thank my co-presenters for being with me throughout these years or past years in these sessions and daring to bear their calamities throughout. So thank you, sir, and thank you.